This is Nicola Ghazi. I'm a veterinary retinal consultant at the Eye Institute of Cleveland Clinic, Abu Dhabi. I want to welcome you all to this session where we will be discussing the management of complex ophthalmic cases that we see in our eye clinic. I have with me here today Dr. Arif Khan and Dr. Jason Goldsmith, and I will let them introduce themselves. Dr. Khan?
Yes, I'm Arif Khan. I'm a pediatric ophthalmologist. I also see adults with misaligned eyes, that is strabismus, as well as patients with genetic eye disease.
Okay, Dr. Goldsmith.
Hi, I'm Jason Goldsmith. I'm a glaucoma consultant here at Cleveland Clinic Abu Dhabi, and I specialize in the management of adult glaucoma and cataract surgery.
Welcome to both of you. Thank you for joining me. So I would like to start off by pointing out that although the three of us are sitting here today to discuss management of complex ophthalmic cases, but it's really not only us in the Eye Institute that deal with these cases. Our colleagues also deal with this in and out every day. We're just representing them here just for the audience to know, and also for them to know that it's not only our divisions that get involved in the care of these patients. Many times we also require the help of our colleagues from different specialties such as the cornea subspecialty, the uveitis subspecialty, the neuro-ophthalmology, optometry, etc., etc. So, but I hope that the three of us will be able to give our audience a flavor of what is complex care and how do we deal with it in our institute. So maybe the best way to start is to try to define complex care. And then later on, after that, maybe we'll go over a quick summary of the eye anatomy for the audience who are not physicians who may be watching us. So let's start by defining complex care. Dr. Khan, please.
So thank you, Nicola. So I would say that complex care would be when you have a particular diagnosis in the context of other ocular disease or systemic disease. For example, one of the most common diagnoses in ophthalmology is cataract, opacity of the lens. And it's one of the most common surgeries in ophthalmology and in medicine in general also. Usually it's very straightforward and outcomes are excellent. But sometimes you might have cataract in the context of an eye that also has uncontrolled glaucoma or an eye that sustained a significant trauma, or in the context of a disease such as uncontrolled diabetes or a syndrome such as Marfan syndrome. These situations become complex and really require careful management, multidisciplinary approach for the optimal outcome. I would also say, staying with cataract in a child is something that would be considered complex because the child's eye is actually growing. It's a moving target, and it's much more prone to inflammation. So this is what I would consider complex surgical care. I'll just add one more thing in regards to cataract, talking about diagnosis. Diagnosis can be complex also. Typically, the diagnosis of cataract is very straightforward. But sometimes we see unusual situations, unusual patterns, where there's actually a different underlying disease causing the cataract, the lens opacity, as opposed to just run-of-the-mill cataract. So that would be another complex situation.
Thank you. How about you, Dr. Goldsmith? What do you think?
Well, in my practice, complex care includes cataracts that are clearly at risk for surgical complications, and we have to take special maneuvers to prevent those complications from occurring. That might include the use of special devices such as the OMED segment, sometimes combined with the capsular tension ring, or often I'll work together with a retinal surgeon such as Nicola Ghazi to manage the case in a way that we can avoid these sorts of surgical complications and achieve an excellent outcome.
Great. So just to sum up, complex cases can be complex in diagnosis, complex in maybe obtaining imaging, diagnostic imaging and other tools for them, and in the management, whether medical or surgical. You agree?
Yes. I'd also make another point. The eye itself is so sophisticated with so many different tissues. It's intimately connected with the nervous system and the blood vessels. So there are many advances in the last 20 years in terms of diagnosis and management, and it's impossible for any one person to be on top of it all. So that's why there's almost a dozen different ophthalmic subspecialties that are available for complex care, and that's why we have so many subspecialists in the eye department. It's just not one eye doctor who can handle it all.
I'm glad you mentioned this. We will expand on this later during the session. But since you mentioned cataracts, glaucoma, retina, I think it would be appropriate now to just give a quick review of the anatomy of the eye, like I said, for the non-physicians watching us, just to get an idea of what we are talking about. So we have this eye model with us, and you can see here the cross-section of the eye model. This is the front of the eye, this is the back of the eye. The front part of the eye, this part here, is the cornea, for example, and sometimes this can be involved in addition to the lens here, which may be involved by cataract. As you can see, it is clear here, but when the lens is cataractus, it becomes white like this. And also all of this may be associated with a retinal detachment, for example, such as in diabetics, where this orange part of the eye has a disease such as retinal detachment. And this is when multidisciplinary care would be required. And this part here around the lens is really the part that is responsible for the fluid inside of the eye, and where the balance is important to maintain the pressure of the eye. And if this balance is off, then glaucoma can develop, as Dr. Goldsmith mentioned, and then this also would require another surgical approach sometimes if medical therapy is not enough to treat it, and it can be part of a complex surgical approach to treat a single patient. So I just wanted to highlight this as a refresher or as a new piece of information for the non-ophthalmic physicians watching us. Okay, so now having defined complex care, did you notice any uniqueness or anything different in the population in the Gulf region compared to where we used to work? So for example, you know, we all trained in the United States. Dr. Khan and myself came to the Gulf area some time back before coming to Cleveland Clinic Abu Dhabi. Dr. Goldsmith, you came directly to Cleveland Clinic Abu Dhabi. Can you tell us what is your experience in the disease population over here in the region? Let's start again with Dr. Khan.
Yes, thanks, Nicola. Well, clearly the diseases we see are different from the diseases in the West. And conditions that are considered a little more uncommon in the West tend to be more common here. This is particularly true for genetic eye diseases, something that I have a particular interest in. And that has to do with the historical, isolation of the population. There's increased recessive disease here. And conditions that perhaps in the United States somebody would see once every 10 years or once in a career are very prevalent here and very common here, and sometimes actually mimic other diseases. So it's something that really adds to the complexity of treating eye disease in the region. Another thing I would say is that disease tends to be more advanced here than what we're used to back in the West. And these two factors, the severity of the disease and the prevalence of rare genetic disease, can be confusing to someone who doesn't have experience in the region, who's just coming out of training from a Western institution.
But you, Dr. Goldsmith, you agree?
I agree, and I agree with Dr. Khan that the disease burden here is greater and that the stage of presentation is more advanced. And in the case of glaucoma and cataract surgery, I see a lot of patients that have already completely lost vision from glaucoma in one eye, and therefore are monocular, only seeing out of their other eye. And this is something that's I rarely saw in the United States, but is quite frequent here. In addition, the cataracts are more advanced, they're denser, they're often associated with a disease called pseudoexfoliation, where the zonules, the little strands that connect the lens to the sidewall of the eye, are sometimes loose and at risk for falling or having the whole lens displace into the back of the eye during surgery. And therefore, one has to take special considerations in advance of surgery and be prepared for complications, and again, try to prevent them.
Yeah, I agree also. Also in retina, in my experience, there is much more prevalence of diabetic retinopathy over here compared to the West. And the disease presents at advanced stages with a lot of associated systemic and ocular comorbidities, which makes it also a bit challenging, as Dr. Khan mentioned, to somebody who's not experienced in these diseases. So this adds to the complexity, as Dr. Khan mentioned, and the prevalence is huge. There's a lot of complex diabetic cases that present to us in the retina clinic. All right. So I would like now to discuss some of the requirements that are needed really, or prerequisites that are needed for an institution to be able to offer the best care for such complex cases. Again, this time I'll start with you, Dr. Goldsmith. So can you tell us, what makes care for these complex cases ideal in a setup like the setup we have here at the CCAD?
Well, first of all, we're a large institute with over 25 physicians, and therefore we have specialists in every area that is necessary in order to treat the individual patient and their particular problems. We have state-of-the-art equipment. In the clinic, we do comprehensive patient workups. We carefully measure patients in order to determine what power lenses we're going to use, special order lenses that are needed for particular patients. And then in the operating room, we have, again, state-of-the-art ophthalmic equipment, excellent microscopes and other equipment that we need to do the surgery. And often we collaborate with our colleagues and bring in multiple surgeons in order to achieve the best outcome in any individual case.
Thank you. Dr. Khan?
Yes, I would add that in addition to the different ophthalmologists and different specialties, we also have allied health personnel who are very, very helpful and really fill a particular niche in caring for patients, such as optometrists specialized in low vision, orthoptists. Orthoptists allow us to take care of children as outpatients in ways that we would not be able to otherwise. We also have an electrophysiological service that allows us to take care and assess retinal disease, particularly inherited retinal disease, that would not be able to be assessed objectively had we not had those tools. I'd like to stress what Jason was saying about the working together. When we face these complex cases, we communicate with each other, whether verbally or via the medical record. And if there's any chance that we need multidisciplinary approach for surgery, there's no problem in arranging our schedules so that 2 or even 3 different physicians or even technicians, ultrasound technicians, are available to do what's necessary for the patient. That's never an issue. And I think that's something very unique here, because it's difficult to do that if you're outside of a setting of an institution.
I agree, and I would like to stress 2 things that you mentioned, Dr. Khan, is the electronic medical record that we have is really conducive to improving care for such cases, where we have at our fingertips all the imaging modalities that were done, all the history of the patient available to us, and now with the addition of Malafi and access to outside documents, we can really understand the complexity behind the cases that we're seeing, as well as review the recent images for them and be able to discuss even when we're not physically present in the same location, in the same office. The second thing I would like to emphasize is the commitment we have for taking care of these patients, where, like you mentioned, sometimes you may need 2 or 3 surgeons. For example, case in point, the case we did a few weeks ago, congenital glaucoma, where you were present, I was present, a colleague from the cornea service was present, because this patient needed such expertise for the best outcomes.
And the ultrasonographer
was present. So we were all available. Our clinics were on hold for us to be available for the care of such patients. So it really requires a lot of commitment and dedication, and we're really privileged to be able to work in a place that offers this to our patients. All right, so maybe it's best to close with some examples, and the journey of such a complex patient when the patient comes to see us. So maybe we'll take, two quick examples from each one of you, going from seeing patients in the clinic all the way to operating on them, and then afterwards, after surgery, what happens after we reach a stable situation. So again, Dr. Khan, let's start with you. So let's say you're seeing a complex patient in your clinic that needs, for example, retina care and cornea care in addition to pediatric care.
Let's take the example of congenital glaucoma again. So congenital glaucoma is more common in this region of the world than most of the rest of the world. And these patients typically present with corneal haze, and when we measure the intraocular pressure, it's high. So the parents actually see that the eye looks abnormal. So a patient like this comes in and is referred as congenital glaucoma. The first thing that we want to do is we have these patients assessed by our orthoptists. Our orthoptists are specialists in assessing and managing children with ocular abnormalities. And they are able to take the vision in these children and take the pressure. And this is really something that's a unique skill. We have patients that are actually come from other countries because their providers were not able to take pressures of the children without putting them under anesthesia. And this is something I'm very proud that we're able to do here. We've never really, very, very rarely had to put a child under anesthesia just to take the pressure because of our orthoptists. The first thing we want to do is make sure that it really is congenital glaucoma, because in most of the world, when you see a child who comes in with a hazy cornea and high measured IOP, intraocular pressure, it is glaucoma. But again, here in this region, we see some rare genetic disorders that are more common here than the rest of the world. One of them is a corneal disorder known as CHED, or congenital hereditary endothelial dystrophy. And these patients don't have glaucoma, but they have a cornea that looks like the cornea in glaucoma. And unfortunately, I've seen several of these patients been misdiagnosed as glaucoma and have inappropriate surgery for that. So we want to make sure that we truly are dealing with glaucoma thanks to our orthoptists and our examination in the clinic. If we have a patient who seems to have significant haze and there's a question if there's a retinal problem, what we do then is we consult with the other physicians on the team, and we arrange for an exam under anesthesia with a plan to do whatever required surgery may be needed at that same setting to limit the number of anesthesias the child may need. After that, the child has immediate postoperative rehabilitation, again with the help of our orthoptists. And once things are stable, we encourage them to follow up with their local providers because we know it's difficult for patients to come and travel distances to come for care here. And there are many capable providers in the community and outside. But sometimes these difficult cases, these questionable cases, require multidisciplinary approach to address the acute problem before they can be managed less acutely.
Thank you very much. Dr. Goldsmith?
So one example of complex glaucoma care that has come up several times is a patient who is at risk for the development of malignant glaucoma after surgery. We've seen patients that have clearly suffered an attack of malignant glaucoma following surgery in one eye, who've then been referred to us, and we've taken a careful approach in which Dr. Ghazi and I operate together, and Dr. Ghazi performs a complete vitrectomy and something called the hyalodonzonuloliridectomy. And then I proceed with cataract surgery and place the lens in the eye in a special way. We use a 3-piece lens, and place it in the sulcus and then perform posterior optic capture to make sure that the lens is completely stable. And this approach allows us to avoid completely the outcome, the devastating outcome of malignant glaucoma.
Thank you. Yeah, I can think of so many other examples. Unfortunately, the time does not allow us to enumerate them all. I would like to mention just, a simple other example, which is a gene therapy that we also offer over here at Cleveland Clinic Abu Dhabi. It requires a complex approach also from physicians, pharmacists, technicians. It's a really complex pathway that patients go through in order to be able to receive this medication that also often requires the presence of more than one surgeon in the room, particularly 2 retina surgeons collaborate to deliver this treatment to patients, as well as expertise, genetics expertise from Dr. Khan in the beginning for diagnosing these patients and referring them to us. So there are lots of other examples that we can really go over. But I think I'd like to summarize by saying that we collaborate intensively for these patients, both in the preoperative phase in the clinic, in the preoperative planning, sometimes immediately before surgery. If you recall, we have these discussions: who goes first, which part of the surgery should go first, which part of the surgery should go second, etc., in order to plan it in the best way possible to achieve the best outcomes. And this continues even after surgery and later on after rehabilitating patients through discussions with the referring physicians when appropriate. So it's really a journey of collaboration and commitment to such complex cases. All right, so I think with this, if you don't have anything to add, I think we're ready to close. We're at the end of our session. Anything else to add, Dr. Khan, from your side, or Dr. Goldsmith?
No, I mean, it's a pleasure to take care of patients and to work with everyone on the team. And as you said, it's a privilege to be able to do that.
Yes, it's such a collaborative environment here at Cleveland Clinic Abu Dhabi, and it's a joy to work here.
Great. Thank you for being with me today. I share your feelings. I also feel privileged to be here. And I want to thank our audience for their attention. I hope that this was helpful and hope to see you in the future in future episodes. Thank you very much.